We'll get going from there. Hello, good afternoon. Welcome to Psychiatry Grand Rounds. I'm Francisco Moreno, and it's my pleasure to welcome you today to our presentation. Today's Grand Round is supported by a grant from Neuronetics, Inc. And I'll be introducing our speaker today. It's my pleasure and honor to welcome a friend and colleague, Dr. Ian Cook. He received his undergraduate degree from Princeton University and then went to medical school at Yale University before going to UCLA for his residency. He has been in the faculty at UCLA and has had tremendous achievements as a professor in residence and a research scientist. He, in January of 2007, he became the first director of the UCLA Unipolar Depression Research and Clinic Program, a component of the Integrative Center for Mood Disorders at UCLA Summit Institute. In May of 2008, he was named the inaugural holder of the Joanne and George Miller and Family Endowed Chair in Depression Research at the UCLA Brain Research Institute. Then in March of 2009, Dr. Cook treated the first patient in the transcranial magnetic stimulation treatment service at UCLA, bringing this FDA-approved device intervention for the treatment of depression to LA. He's also one of the inventors of trigeminal nerve stimulation, and I hope that if he has enough time, he'll tell us a little bit about that before we close at the end of the hour, which is being investigated for the treatment of epilepsy, depression, PTSD, ADHD, and other disorders. Dr. Cook is Chief of Staff at the Resnick Neuropsychiatric Hospital, and in addition to his work in academia, he's also volunteered to support a number of professional societies. We had collaborated together in executive boards. We were both involved with the West Coast College of Biological Psychiatry for a period of time as well. And he's just a great citizen, and happy to have him come here to present to us advances in neuromodulation in psychiatry. Please help me welcome Dr. Ian Cook.
Thank you for that kind introduction, Francisco. Thank you all for having me here. It's great to be here in Tucson to give this presentation about what I think of as one of the very interesting and exciting new areas of work where we're getting rapid translation from fundamental science to clinical innovation. I have disclosures as shown here and also on your website. And of note, I guess, is that some of the devices that we'll be talking about today, the Neuronetics system, I am on their Speakers Bureau and get some research support from them. One of the, if we have time to talk about trigeminal nerve stimulation, that is a technology invented at UCLA. I'm one of the inventors, and those patents have been licensed to NeuroSigma. So what I'd like to really think about with you today is about how this fits into what we do in psychiatry and mental health. We know that medications, that psychotherapy have helped many, many people with major depressive disorder and, of course, lots of other psychiatric illnesses, too. But we have the problem that many people either don't get well with the medications that we offer to them or they can't tolerate them because of side effects and adverse events. And so this question of, well, what else can we offer to them? And when should we offer that in our treatment algorithms is, I think, one of the pressing questions that we're all struggling with and thinking about how best to use some of these alternatives. Brain stimulation or neuromodulation are modalities that offer some valuable alternatives, and what I would like to do today is really sort of think about what these different forms of brain stimulation are, how they're different from our classic neurochemical approaches to the brain, and then how to think about their clinical uses. So to start things off with a clinical grounding, the case of Mr. A. Gentleman in his late 40s, he's having a recurrence of major depressive disorder, and this time around it has been refractory in your hands thus far to using an SSRI as monotherapy. That didn't work. Switched him to an SNRI. That didn't work either. Tried augmenting that with aripiprazole. Some side effects, not much more benefit. An off-label combination using an SNRI plus bupropion, again something that's been written about in the literature a good deal, or that plus methylphenidate as well. Sometimes people call this California rocket fuel. Stephen Stahl's idea, not mine. But none of these things really did it for him. And now, because his job is cognitively demanding, he is reluctant even to consider ECT. And besides yet another round of medications, what else can you offer to him? And I would suggest to you that neuromodulation may be something that we can think about offering now and into the future in greater varieties. Some people describe the psychopharmacologic options as looking sort of like this. You're on the highway, you have lots of options, but they all take you in kind of the same general direction. Neuromodulation is different, and just to clarify, when I talk about neuromodulation and brain stimulation, most people use these terms interchangeably, and I think that for the most part they are. Although philosophically there's a little bit of a difference. When you talk about brain stimulation, you're talking about, all right, I'm trying to stimulate the brain, certain parts or the whole organ. When we speak of neuromodulation, the conceptual thing is that we're trying to modulate the activity of parts of the brain. Maybe stimulate, maybe inhibit. And so I think of neuromodulation as being sort of the broader term, brain stimulation being a more focused version of that. But whatever you call it, it's really quite different from how we thought about what we do so far. We think of, for 50 years, so much of our thinking has been dominated by aminergic hypotheses. Prior to that, our psychoanalytic traditions were there as well. And ECT has sort of been out there on the edge for much of this time. But really, if you ask most psychiatrists, what do they do? It's either therapy or meds which are based upon just a handful of different molecular themes, if you will. This is just different. Here we're thinking much more about how probably neuroplasticity is a central part of the mechanism of action of much of what we are currently labeling under the neuromodulation aegis. And part of that is that we might expect to see things that are just different than what we've been able to see so far. That you might be able to produce effects leading to a change in one neurotransmitter in one region going up, and at the same time going down, a different neurotransmitter going down somewhere else, all as a result of your same intervention, not combining, not like a little bit of molecule A and a little bit of molecule B in a combo pill, but really the same therapy, the same intervention leading to two different or multiple effects. And we actually have some PET data about that. It's not in the slide deck, but we can talk about that later if you'd like to. So this slide from Mark George's book really gets to this notion that we have focused on the chemical part of the story a great deal, sometimes leaving out the electrical part. But of course, when we think about the brain using 20% of the body's glucose supply, where's most of that metabolism going? Well, it's actually not going to make more neurotransmitter. Most of it's going to keep the electrochemical gradient across the cell membrane, which is there basically for the electrical signaling to take place. So if you can connect the dots without a whole lot of effort there. When we speak of neuromodulation methods, conceptually there are two broad categories. There are those that are convulsive, that induce a seizure as part of the therapeutic cascade, and those that are non-convulsive. And of course, ECT there, let's see, I'm supposed to use the mouse as a pointer. So ECT is of course the granddaddy here. A variation called FEAST, focal electrically administered seizure therapy, we'll touch on very, very briefly. An experimental thing that is being worked on, as is magnetic seizure therapy. But there, the commonality is that these are all therapeutic, are thought to be therapeutic because they produce a seizure. There are a whole set of other things that don't. Vagus nerve stimulation has been around for a number of years. We'll look at that briefly. Deep brain stimulation has been used in Parkinson's for many years, has approval for use humanitarian basis for OCD, being examined investigationally for other conditions too. We'll touch about that briefly. These other things, epidural prefrontal cortical stimulation was published on a couple years ago. Cranioelectrotherapy stimulation has an FDA indication. Transcranial magnetic stimulation, of course, is the thing that's gotten a great deal of attention in the last couple years. No. I'm told don't use a laser because it doesn't go on the video. So, but thank you though. And then trigeminal nerve stimulation, something that's new that's come out of UCLA that we can talk about if time permits. So We practice evidence-based medicine these days. We want to know what's the evidence, what's the quality, what's the quantity of it, how appropriate is it to the patients that we take care of, and we have a number of bodies that weigh in on this. The Canadian Network for Mood and Anxiety Treatments, the CANMAT group, published these recommendations on neuromodulation, neurostimulation in 2009, and as you can see, ECT they thought of as having level 1 grade evidence for its use. RTMS as a second-line treatment, they said also was level 1 for its acute efficacy, not quite as solid a database for some of these other issues. VNS they thought has a third-line position, and DBS they thought of as being investigational for things like depression. The APA caught up in 2010. I should, in the interest of full disclosure, I used to be on the executive committee for the Practice Guidelines Project at the APA. I've since stepped down from that, but these are the folks who review the literature painstakingly, go through all the evidence, and say what is there that we can justify, what is still in need of more research. And they concluded that for treatment-resistant depression, ECT was the most effective form of therapy, but that TMS is there. It deserves a place in our armamentarium for treatment, and VNS is there for people who have a more selected group of folks who have not responded to at least 4 trials. So we have major bodies who have gone through and said, this is not experimental, this is here today, and we should be thinking about using it. But of course the question there is using it for what indications, for what patients. This is the image of ECT treatment devices from the long past, but the image that endures in most of the public's mind is, of course, here on the left, Jack Nicholson's movie portrayal with all its dramatic license. Still, after over a quarter century, still casts a very long shadow in the minds of the public about what ECT is about. I think a more enlightened and current perspective is very nicely articulated by Kitty Dukakis in the book Shock, describing her own experiences with ECT. And if you have patients who are wanting to learn more about this and not read just the extremes that people post on the internet, it's a useful narrative, which I would recommend highly. So we think of ECT as something for our refractory illnesses. It, of course, goes back to the 30s in Italy when it was used as an alternative for chemically induced seizures, and then it was first brought to the United States in 1940. It's administered under general anesthesia, not like in the old days. The people are unconscious. People do not experience pain because of the use of medications. With the seizure, there's usually a transient bump in their blood pressure and heart rate, and intracranial pressure, which leads to some of the contraindications that we think about for using it with people with space-occupying lesions and such. Post-ictally, there may be some confusion. That usually resolves very briefly in the recovery room. And one of the things that people have noted is that the questions of amnesia and other kinds of cognitive disturbances that have been present for many, many years are still an issue. Fortunately, they are generally relatively short-lived. But they can persist for longer times in some smaller subset of patients. We use it with evidence-based to support it in depression. It also works in mania. For the trainees, if you have a patient with mania that just doesn't respond to your best pharmacotherapy, this is an option to think about at least. People have examined it and found it to be useful in schizophrenia, including patients who don't respond well to all the usual kinds of medications. And there is less evidence, but still some evidence, that it may be useful in delirium, in Parkinson's disease, in NMS, and actually in status, where you may be able to induce a seizure that then breaks the ongoing spontaneous seizure activity. Because the cognitive side effects are one of the still large problematic areas here, people have looked at the question of, well, what can we do that's different that might lead to this being less of a problem? And this speaks to the so-called the feast idea, where depending upon where you place the electrodes, you can, which are shown schematically in the upper row there with the yellow areas, you can determine where the electric current then flows through the brain parenchyma, and from that, where the seizure is most likely to be most intense, and from that, what the side effects are likely to be. And they're depicted over at the far right of the screen is the so-called feast design, where you have a smaller electrode in the front and a big electrode in the back. so that you just cause the currents to flow in the ways depicted there in the diagram in the second row. Limiting the seizure, limiting the current flow to areas where you may not get as much of a cognitive disturbance afterwards. So still experimental, still being examined widely. Holly Listenby, now at Duke, has been one of the proponents of this, as she's also pioneered the work of magnetic seizure therapy, where you actually cause a seizure to happen by inducing a current with a magnetic field that changes rapidly. So some of the things that other people are looking at are the questions of shorter pulses or different waveforms rather than a square or rectangular sort of pulse. But these are all the options which are still there in the investigational pipeline. Vagus nerve stimulation has been around for a number of years. Started out in epilepsy and then migrated to use in depression. And of course, it's important to recognize that the idea here is that the vagus nerve, about 80% of its fibers are actually afferent fibers, bringing sensory information up into the brain, and that this connects to a number of important regions that we think of as being important in stuff like mood, like the locus coeruleus, the amygdala, and the bed nucleus of the stria. So back in the mid of the last century, people started stimulating here, noticed that there were EEG changes that happened, and then in '85, Zabar demonstrated an anticonvulsant effect in an animal model, both in terms of stopping a seizure that was ongoing by turning on the device, and that with long-standing use that you could actually have a long-standing inhibition too. First tried in epilepsy in '88, and my good friend and colleague Krista Giorgio was part of this group. Looking at it in epilepsy, also reported that people's mood improved too. An interesting observation for the trainees. Never underestimate the power and importance of being a good observer. You never know where that will lead you. This led to testing in an animal model, the so-called Porsalt forced swim test, where they all showed benefit in terms of looking like an antidepressant. And in 2000, the first human was implanted, leading ultimately to a sham-controlled trial, published by John Rush as the lead author in 2005, and then some more subsequent open-label and randomized trials too, suggesting that there is a benefit in excess of the sham stimulation, where the machine is implanted but not turned on, or is implanted and turned on but not given the same kind of biological signal that is thought to be efficacious. Interestingly, when we think of taking care of depression, most of our modalities that are pharmacotherapeutic or even psychotherapeutic tend to give a benefit in a relatively short amount of time. That's half a joke, because of course, for the patient who's got depression, waiting 4 to 6 to 8 weeks to seek therapeutic benefit is an awfully long time. But compared to a year, which it takes for VNS to be clearly beneficial, it's a lot shorter. So when people first started using VNS, the notion that, gosh, there were these long-term benefits that might accrue over many, many months of use was a sort of a different conceptual model than what we had been prepared to think about from all the years of focusing on pharmacotherapy. For patients, when CMS decided that they were not going to pay for this under Medicare, and then many insurance companies took their lead from them, the ability for people to have access to this kind of a modality was greatly curtailed. Cyberonics, the company that has the intellectual property and the approval for this device, may make some further discussions with the CMS and see if they can reopen that dialogue, and perhaps this will become more available to patients. But right now, it's approved for treatment of epilepsy. It's approved by the FDA for treatment of depression, but really epilepsy patients can get it, and people with just depression, have a much harder time. I think my colleagues in neurosurgery estimate that we maybe implant 4 a year at UCLA for depression, and that's of course all self-pay. So it's a little bit challenging for many people. With VNS, a generator is implanted in the pectoral wall, usually near the clavicle. The lead is tunneled under the skin through the neck, and then helical shaped electrodes are placed in contact with the vagus nerve. And so there is a surgical procedure that's involved, and then every so often, every few years, a battery swap out happens too. But the electrodes are usually left in place for that. Which patients would be eligible for VNS? Well, people who have who have chronic and recurrent forms of treatment-resistant depression are the ones who seem to show benefit. The CANMAT and the APA guidelines both suggest that it should be for people with major depression, unipolar major depression, and who have had at least 4 prior treatments of adequate dose and duration. Harold Sackheim published some interesting work looking at predictors of who would get well with VNS, and found in particular that those who had already had ECT before they came to VNS were not as likely to do well. That not having had ECT before conferred about a 4-fold increase likelihood of doing well with VNS than if you had had ECT. I think of this as probably having had ECT as being a marker for having a very bad form of the illness, rather than that ECT does something to the brain that makes it then unresponsive to VNS, though that's still an unresolved question. One of the challenges here is that predicting who will do well with it is still difficult. We don't have good clinical predictors. We still don't have good biological predictors of this. And so people are then unfortunately placed in the position of, well, shall I self-pay for a surgical procedure with an unknown likelihood of benefit? It's a hard decision for many people to make. But that's where the current state of affairs is. How about TMS? Well, the R stands for repetitive, as opposed to just single pulses of a magnetic field. And this is sometimes jokingly called the overnight sensation a century in the making. At the risk of inducing flashbacks to college-level physics for some of you in the audience, this, of course, stems from the notion that electricity and magnetism are 2 sides of the same coin, that when you have an electric current flowing through a coil of wire, it sets up a magnetic field, and conductive material near there, like wet brain tissue, is then going to have a current flow in reaction to that. One of my colleagues describes this to patients as sort of like an electric toothbrush, where you don't have an electrical contact to recharge the batteries, but the battery sits in the machine, and the magnetic field gets the energy from the base station to the device. People have been looking at TMS in various forms, or magnetic stimulation in various forms, for around a century. The gentleman there in the picture is none other than Sylvanus Thompson, who found with this very interesting and elegant-looking machine, well, maybe elegant attire for him, not so much for the machine, that you could get retinal phosphines when you pump electricity through these rather large coils. Things were at a low level of activity until the 80s, when Anthony Barker first published use of it as a neurodiagnostic tool for stimulating the motor cortex and then being able to observe whether the outflow tract was intact. You know, for years people had been able to do so-called evoked potentials, where you'd stimulate a sensory nerve and then monitor for an EEG response in the brain. Now they could look for objective evidence of integrity or lack of integrity in outflow tracts too. And then in the 1990s, the notion of not just doing a single pulse here and a single pulse there, but stacking them together grew out of some interesting work, some of it with animals, some of it with people, but the notion that gosh, when you stimulate nerves over and over again, you can get long-term potentiation or long-term depression as the lasting neuroplastic changes in a circuit. And Mark George then connected the dots to using this as a therapeutic in depression and published the first human report in 1995, a neuro report, with this kind of a diagram. And here we have the Hamilton Depression Scale plotted sort of upside down from how many of us think of it, but basically down is worse. So the depths of depression are at the bottom, and as you can see, the person had some increases or improvements in their scale as time went on. The red marks at the bottom depict when treatments were being given. And this is first case, gosh, what do we do? And so there are treatments, and then there are gaps, and then there are more treatments, and prolonged periods of moderate wellness compared to a score of something in the mid-20s. A score of 10 is pretty good. And then ultimately there we see recovery around day 90, and some PET scans showing that indeed it's not just an imaginary improvement, but something that has a biological basis too. In the old days, the coils looked more like those depicted on the left. although the figure of 8 coil is still commonly used in neurodiagnostic circles. But now we have the system that's depicted on the right, where a magnetic field is emitted from a coil in a device that's on a gantry that's not shown in this picture, but that holds it in a precise position over the person's head, in contact with their head for the treatment, so that it's not relying upon the white-coated investigator there, that's Ziad Nihas, holding it for 30 minutes in exactly the same spot. These things weigh maybe 8 to 10 pounds, so it's a good workout for the investigators, too. Amongst the things that we think about when we think about TMS is that the nomenclature is very different. We think not so much about methyl groups and cyclic structures, but we think about the constituent components being things like a pulse, which has an amplitude and a duration. These pulses can be stacked together in so-called pulse trains. And then these trains then can be alternated between active and off periods, letting things like a magnet cool or let the brain circuit be quiescent for a while and let neuroplastic changes happen. And then these are packed together in a treatment session. Treatment sessions often last for around 30 to 40 minutes and consist of pulses and then quiet periods, in part in response to some guidance from the NINDS a number of years ago when they wrote a document and then revised it more recently, looking at how do you do this in a way that doesn't lead to people having seizures that are undesired? Because if you stimulate too much, there's a theoretical and a real risk of inducing a seizure. For example, if you are pulsing over the motor strip, over the motor threshold, you do it over and over again, you're going to lead to a seizure. So things like, don't do that. Pulse in a different location. Pulse in a way at a strength and at a frequency rate and a duty cycle that are different. And these safety features have become widely accepted. Another thing that's very different about using TMS compared to meds is that we think about where in the brain we're going to stimulate a lot more. And one of the ways in which one navigates to the so-called target is to find the motor strip. And the homunculus here is very familiar to everyone. And in fact, for most ways in the way that the FDA cleared this was to find the part of the motor strip that controls the thumb. And one positions the magnet over the scalp and finds where is the motor strip and where is the thumb part of the motor strip. And then you have to then find out, well, how strong should the magnetic field be in order to produce stimulation? When we first got our machine, I got to be the test pilot for all my staff to practice on. And so we discovered I have a pretty thick skull, and so I need, that was supposed to be a joke, guys. And so we need, for some people, you need a stronger magnetic field than for other people. Likewise, if a person's on a medication that is anticonvulsant in some way, like lamotrigine, you might need to use a stronger magnetic field in order to cause those depolarizations to happen. If someone's on something that is proconvulsant, bupropion, atypical neuroleptics, lots of other meds, you will require less to get neurons to depolarize, and therefore you need to think about the seizure risk there a little bit differently. But we think of, here's where neuroanatomy actually comes into practice on a daily basis when I'm taking care of patients with TMS. What are the biological effects of it? Well, we know that very acutely you induce an electric current. This leads to depolarization of the neurons in the cortex underneath there. But there are also firing changes that then happen in the neurons that are 1 or 2 synapses away. You're really stimulating the entire circuit, not just the chunk of brain underneath where the magnet is. And in animal models and in human models, this leads to things like changes in monoamine concentrations, in salivary cortisol. There's some evidence that you can induce the genes for neurotrophins. And the bottom line is that when you stimulate over an area like the dorsolateral prefrontal cortex, you get alterations in activity not only there, but in other parts of the brain that are part of the limbic system, like the anterior cingulate too. And here we have some SPECT data looking at pre and post differences in activity in people who receive TMS. The magnet goes about here. Whoop, where'd it go? It goes around here, and so not surprisingly, we're seeing some changes in activity that last right underneath where that is, but also in areas like other parts of the limbic system as well. When reading the literature, it's, I think, very important to think about it as really being in a couple of different eras. The early clinical studies, I think we can think of as being like dose-finding studies. People tried many, many different permutations, different targets, different stimulation parameters, frequency, numbers of trains, numbers of pulses, how many pulses did you give in a week, did you do it every day, did you do it every other day, lots of different things. And sometimes it worked and sometimes it didn't work at all compared to sham. And the early Cochrane reviews of these data suggest that, gee, this isn't working. Well, I would suggest to you that if you did a study of, say, if it was 1985 and you did a study of a molecule, say, fluoxetine, and dosed it at 5 milligrams a day for 2 weeks, you might not see a whole lot of clinical change. But that doesn't mean that the molecule is worthless, as Eli Lilly and now generic manufacturers have discovered since then. As the literature evolved, people kind of converged on what seems to be the most useful way to do this. And it seems that you need to use at least a large number of pulses, like 3,000. And if you give them all in fast rates over the left dorsolateral area, you're very likely to be able to detect a real therapeutic benefit. And now 2 meta-analyses have both shown that that's the signal that comes out of the literature if you look at the more current literature, even if you don't look at things like the registration trial that led to approval for the Neuronetics device. And the effect sizes also change about 0.35 for the early trials, and now an effect size of about 0.76 for the more recent trials. The first big sham-controlled trial was the Neuronetics registration trial, 301 evaluable patients, all with unipolar depression, not psychotic, and it was a 6-week treatment trial. People came in Monday through Friday, with time off for holidays and stuff like that, stimulated fast, 3,000 pulses at 120% of the motor threshold. And at the end of the 6-week period, people were then tapered. So rather than stopping it abruptly, they went from 5 treatments a week to 3 for 1 week, for 2 the next week, and 1 the next week, and then off, and started pharmacotherapy at the time and could enter a 6-month follow-up study at that point. Holly Listenby published a very interesting article looking at the data and trying to figure out, well, for whom does this work really, really well? Clearly no treatment that we have works for everybody, but can we pick the right people for whom this would be of benefit? And so they looked at questions like age, like gender, employment status, treatment resistance in the current episode, duration, comorbidities, all kinds of things, all the usual suspects, if you will. And in their analysis, they found that really the only statistically significant predictor was how many treatments a person had failed in the current episode, not lifetime. So when people come in to me for clinical care and say, I have tried everything under the sun, I ask, well, when was the last time that you felt well, and what have you tried since then? Since that seems to be the index that matters the most. And so this is what led to the FDA's guidance and their labeling, that it's indicated for treatment of major depression in those who have failed 1 prior antidepressant treatment at or above the minimum effective dose and duration in the current episode. Now, again, remember that in the real world of care, people typically try it's been found, about 4 different tries at getting a true therapeutic trial for every one that they actually complete. People give up all too often before they even get to an adequate dose and adequate duration, in large measure because of tolerability problems, it seems. So this is the labeling, and if you look at that population, that subset of people from the registration trial, here the active treatment people are the ones in the green, the sort of the bluish lines with the squares, and the gray lines with the circles are the people who got the sham treatment. Basically, they came in, they sat in the chair, they had the magnet position on their head, but there was a metal shield that blocked the magnetic field from getting into their brain and inducing the signals there. And whether you measure the outcome with the MADRS scale or with one of the variations on the Hamilton Depression Rating Scale, there's a separation that one sees. Interestingly, a lot of the action happens early, happens within the first 2 weeks. If you think about what you've seen in the past about time course of medication response from STAR-D, in the interest of full disclosure, I was part of the STAR-D gang, sometimes the STAR-D mafia, we were called. We learned that of people who would remit in the first 12 weeks, half did so in the first 6, but half took between week 6 and week 12 to get there. So there are slow pokes in pharmacotherapy as well. Here, it seems like there's a lot of early effect, which is very intriguing and I think encouraging. There haven't been head-to-head studies of TMS versus other treatments, but if you were to look at the STAR-D data as a reasonable historic benchmark, STAR-D is on the left, and for those of you who don't remember, it was multi-tiered trial designed to look at the question of what do you do if initial pharmacotherapy with an SSRI doesn't lead to remission. And so we found that about 28% of people would remit with the first round of treatment with an SSRI. That fell to about 21% for people who had already failed to do well with one. By the time you got up to level 3, the numbers are more like 16% and around 7% for people who have to go to the 4th level of treatment. And this maps roughly onto the so-called ATHF, the antidepressant treatment history form, levels of grading of medications that have been tried and failed to lead to benefit. And there, with TMS, we see about 26% of people making it to remission with RTMS who have failed who have failed to benefit from one round of treatment, going to 18% for level 2 and 18% for level 3. And it gets smaller as you get out to higher levels of treatment resistance in that study too. So that may be part of why the FDA really focused in on level 1 as being where the action was. Whenever there's a new treatment, you always want to know about safety. Efficacy is good, safety is important too. In the registration trial, there were no seizures that happened with over 10,000 treatments being administered. People followed the rules and did it well. After it's been released on the market, there have been, I believe, 6 events, which translates to less than 0.1% per acute patient treatment period. If you think about, if you go and look at the PDR for any of the antidepressants that you prescribe, you'll see numbers which are, well, intriguingly higher. Importantly, there are no systemic side effects that come about from TMS. No weight gain, no sexual dysfunction, no nausea, dry mouth, sedation. Also no effects on cognition. So compared to some of our other treatments that are available, this is a rather benign effect profile. The most common adverse event were headache and scalp discomfort during the treatment, and as someone who's sat in the chair and gotten lots of pulses, the feeling is one of something is tapping on your head, to the point where I have to show patients, look, there's nothing mechanical that's coming out and hitting your head, although it will feel like that. When the electric current induces the pulse inside the brain tissue, there's also soft tissue in the scalp that gets a current induced in that too. There's a contraction and a sensory event that goes along with that, and that seems to be what is producing this very curious and odd effect. If you were to go to the gym and do 3,000 repetitions with a certain muscle group, that muscle would be a little bit fatigued afterwards, and it seems that probably that may be the explanation for why there may be some headache for the first couple treatments. Interestingly, if it does happen, it tends to dissipate, and we have people who at the first treatment say, I don't know about this, and by the end of the first week, they're quite relaxed and falling asleep if they want to. So it seems to be pretty well tolerated. Importantly, especially in kids, we worry about suicide stuff, and of course we now have black box warnings on all of our antidepressant medications. Here we have the suicide question from the HAM. The blue line at the bottom is the increase in people who had active, and the gray line that goes up is in people who had the sham. So it definitely does not seem to be causing suicidality. It seems more likely that as people get better, their score on that item is going to improve as well. Whereas people who don't get effective treatment tend to feel worse over time. Newsflash. Having the company-sponsored trial is informative. It helps get it onto the market, but of course we always want to see what's some independent corroborative data. And now we have the 300 people from that plus almost 200 people from an independent study, the OPTMS, Optimizing TMS trial. Mark George was the PI for that. Here it was 3 weeks of double-blind treatment to the primary outcome, and then 3 more weeks that people could get. They would get the same treatment if they were better, and then they would switch over to open-label active treatment for sure if they were not. In their intent to treat sample of 190 people, they had 3-week remission rates of 14% in the active versus 5% in the sham. statistically significant, and an NNT, a number needed to treat, of about 12, which is in the range where people think this is a therapeutic option that is useful. Interestingly, if you go out to 6 weeks, the remission rate was around 30%, suggesting to me at least that maybe you really do need to treat people for like 6 weeks, as the FDA labeling says, that 3 weeks is just too short. We shouldn't have ECT envy and want to have something that works immediately, that we may have to wait a little bit longer. Let me show a very quick video that tells it from the patient's perspective.
I found these pictures of Julie Anders and I, and we were singing the reprise of 16 going on 17 here.
Millions remember
Yes,
Charmian
no.
Carr as the 16 going on 17.
There is, but I think we're just gonna lose too much time if we do that. That's okay. That's okay. Charmian Carr was she was Liesl in The Sound of Music. She came into us for treatment, and actually, let me let the video run while I give you the quick narration. We're in LA. We get lots of celebrities who want treatment, and most of the time they would like to be anonymous. And so we asked her, what pseudonym would she like to be registered under? And she said, hey, if this works, I want to tell the world. I don't want to keep this secret. And I will direct you to our website where we have it. The bottom line is that for the first time in many years, she was able to get off meds. She had a horrible tremor that she talks about from her lithium augmentation that led people to think that she had Parkinson's. And here she really eloquently tells her tale of being able to getting back to dance class. And for those of you who remember The Sound of Music, she was the character. Her character was the one that did the dance in the gazebo at night. So especially poignant kind of an event for her. I'm sorry. Time is short. I'm told that you stop very promptly at 5. So in the interest of having a couple minutes for Q&A, I'll just tell you it's on tmslosangeles.com. Actually, I've gotten a lot of email from people around the country who have watched it and said, thank you for having it there. Tell her thank you for having it there, because it's really made it possible for me to decide to go forward with this kind of a treatment. If you were to look at the APA guidelines and think about that along with the FDA labeling for the NeuroStar system, after the first treatment has not done well, you can do the usual stuff, a medication switch and medication augmentation with something more conventional, or leading on to something like an atypical antipsychotic medication, all of which are things that are on label, where people then are going to need to be on ongoing pharmacotherapy with multiple medications for a while. Or you can switch to TMS right then, where it seems to have its best kind of outcomes. Interestingly, a lot of times people who have not done well with medications before TMS seem to be able to stay well with just simple pharmacotherapy, with a single antidepressant medication afterwards. And this is, of course, one of the questions that I think is going to need some more investigation as to what do we do once a person has gotten well? Do they switch to, should everyone be put on medication? For people who really have bad side effects, can we use periodic treatments with TMS as a maintenance kind of therapy like we think of in ECT? These are unresolved questions, but investigations hopefully will be ongoing to give us some data about this soon. One of the questions that we're looking at UCLA is the question of, can we predict on something other than past history whether a person is likely to do well with TMS? For many years we've looked at EEG-based biomarkers to try to predict response to medications, and my current R01 and my challenge grant RC1 are both looking at a prefrontal indicator to see if we can actually have a clinically useful biomarker that we could use. We've started an exploratory study at UCLA where we're looking at how changes occur in people who are getting TMS. These are so-called accordance change maps. The very telegraphic version is that yellow means no change, red means an increase in activity, blue is a decrease in activity. And this is an EEG measure that we have previously shown through simultaneous EEG and O15 PET studies to be pretty well correlated with regional blood flow. So in essence, what we're seeing is that in a person who, in this case, this is just a pair of cases, that the person who got well showed that over the first week of treatment, over 5 treatment sessions with TMS, the areas of red, the left dorsolateral prefrontal cortex, had an increase in activity. Other areas too, whereas the person who didn't respond their brain did not give that kind of a shift in activity at all, even though they got treatment in the same anatomical location, the same treatment parameters. So we're in the process of acquiring more data to try to look at this, because if we could know after a week of treatment whether this was the right thing to do, that would help many people who are wondering whether they should undergo this sort of a process. A lot of areas are still the focus of research. Using TMS, we know it works pretty well for depression. Almost 500 subjects in double-blind controlled trials. We have a lot more sparse data for other clinical questions. Hallucinations, some people have reported that if you stimulate at a low frequency, that leads to long-term depression rather than long-term potentiation. Over the temporal parietal areas, you may be able to address persistent auditory and visual hallucinations. Tinnitus may be addressable this way. Bipolar depression, here the results are really quite mixed, with some clinical studies suggesting that you can have a clinical benefit, others being more equivocal. And there was an interesting publication in the current issue of Biological Psychiatry. Jed Rose is the lead author, where they looked at nicotine craving and how that could be modulated by stimulating a different target, the superior frontal gyrus. So there's lots more to learn. These are really still the early days of using TMS as a therapeutic modality, even though it has been around clinically since Mark George's paper in 1995 and historically for even longer. But gosh, the brain's kind of a complicated place. And we have been so focused on thinking about the neurochemical part of the story for so long, thinking about the electrical parts of the picture is a different way of thinking than what we've become accustomed to. A few words about DBS, because I know there is some work here to move forward with this as well. It's investigational. In 2005, that august medical journal, the Wall Street Journal, trumpeted the next generation of shock therapy. Of course, it's not shock therapy, but we don't really expect journalists to be all that accurate. In psychiatric areas, but this, of course, has been used in Parkinson's for a number of years, cleared by the FDA in 2002. A humanitarian device exemption was issued for refractory OCD in 2009. But in depression, the early reports really came out of Helen Mayberg's group in Toronto. She's now at Emory, and Ben Greenberg at Butler and a hospital in Brown in Rhode Island. The idea here is that by sending signals into certain parts of a circuit, you can disrupt the circuit function. And the targets are many and varied. Helen has focused largely on a subgenual cingulate target, in part informed by prior works that suggest that this is an area where the circuit involved in regulating mood is active. But there are other targets too, the subthalamic nuclei, nucleus accumbens, looking at the ventral internal capsule or the ventral striatum, and the ALIC. These are all targets which people are examining in clinical trials, either in the last few years or currently. So we will learn more in the coming years, but even now we have some data out of Helen's group and Lozano's group, where here we have the first 6 and then 14 more that they published back in 2008. Response rates of 35% at a month, 6 months, and 60%, with some up and down, not surprisingly. Unfortunately, one of the problems was that, and here the red line is remission rates and the yellow is response rates. I'm sorry, other way around. Remitters are the yellow line. Unfortunately, about 13 of the 20 had at least one adverse event during the course of their implantation in the first year, which means I think we still have some technical problems to address to make this something that can be more clinically useful. Just recently, Sid Kennedy published on up to 6 years of follow-up on these same 20 people. By the end of year 1, there were 16 folks to study. 2 had been explanted. 1 had left Canada. 1 was lost to follow-up. By the end of year 2, there were 14 left. Another person had been explanted. 1 had died from cancer unrelated to the DBS. They had 2 probable suicide deaths and 2 other attempters. So while clearly the scores are better, and this is a highly refractory group of patients, there are still some issues that we need to address before this can be adopted in a wider area. That said, the notion that we need more treatments for depression is really quite widespread. 18 million American adults have a bout of depression this year. That's a lot of folks, and many of them don't do well with the medications that we have. Shout out to JP Longeman, who is the lead author on this paper looking at PTSD treated with DBS. Here's an animal model where the rodents were exposed to an inescapable shock model paired with a stimulus, a yellow tennis ball, as a traumatic reminder. And ordinarily, an unperturbed rat will explore the environment, play with things. Once they pair the foot shock and the tennis ball together, the behavior is to bury it, to avoid seeing the traumatic reminder by burying it. And I don't have the videos in the slide deck, but there are beautiful ones online showing really radically different behaviors by using DBS into the amygdala to treat this. So hopefully there will be a human trial in the not-too-distant future. To sum up, and we can come back to TNS if time permits and if there are other questions, we really do need alternative treatments to our standard medications and our psychotherapies. And I think neuromodulation has evidence to show that it really holds much promise. While ECT continues to be refined in practice, there are many more novel things that are on the horizon or in the pipeline development. And even now, we have RTMS as a wonderful alternative. It's FDA approved. There are now over 350 installations around the United States where people are using this day in, day out to treat depression, including our place at UCLA. So with that, let me thank you for your attention and take any questions that you have. Yes?
Antidepressant medications, the ECT, have been shown repeatedly to augment serotonin neurotransmission. Does TMS do similar things to serotonin?
So the question is, does TMS also affect serotonin? It has been shown in some animal models to affect monoaminergic transmission. We don't have human data about that, to the best of my recollection of the literature. But there may be some commonalities there, too. Yes?
Are you using it in a maintenance fashion? And if so, what % of your patients require maintenance therapy?
So are we using it in maintenance therapy clinically? At this point, we use it in maintenance in a very small minority of patients. Most often people come to us clinically for care on meds. They are really hesitant to give up the meds that they're on. And so most of them we treat with them being on a variety of different medications. And then at the end of treatment, often they're better and we can jettison a few agents. We have had a couple people who have pursued maintenance treatment where our model has been we wait for symptoms to reemerge and then give some treatments. The other paradigm that people are looking at is, well, if you just have people come in, like with ECT, rather than every day, you go to once a week for a while, every other week for a while, once a month for a while, on into the future. Would that paradigm work? And the trouble that we have right now is we don't have data to say which is better, and so people do it empirically. Off-label. Yes.
While you show the rate of remission, 2 questions. Were those people treated before with atomic psychotherapy, and how many people were involved in those kind of studies to set this kind of rate of remission?
For the TMS trial? Let me see if I can scoot to that picture. This one? This one. I don't have the ends at the tip of my tongue to tell you what the sizes were. This is in the Demetrac and Thais article, though. They do say what the sizes were. In order to be in the trial, people had to have failed pharmacotherapy. I don't believe there was a requirement for having tried and failed psychotherapy. That was sort of an option, but that didn't I mean, just as with Harold Sackheim's work with the ATHF form, psychotherapy is not one of the antidepressant treatments that's listed. But it's a great question. We don't have so much data on that, and increasingly I'm appreciating that there is a group of patients who want nothing to do with meds at all, and they see psychotherapists endlessly sometimes, and they would be open to something like this perhaps. We just don't have data on that.
Very interesting that mission.
Thank you.
Are you seeing a symptom dimension component or trend in your data that you're going into the dorsolateral prefrontal cortex? Are you seeing improvement in symptoms that are associated with those circuits, or?
Great question. In the initial analyses of the data set, people looked at the usual subscales. So looking, is it more neurovegetative, is it more cognitive, is it more anxiety? And it seems to be pretty much across the board. So it's not just circuits that run through DLPFC, it's other parts of the overall depression, I don't want to say depression experience, but the whole syndrome tends to respond. It's not just good for part of it. Yes, please.
Treatment resistance mean that they'll respond, you said it's a predictor of response. The people that are treatment resistant are the ones that respond better, or is it just that this is expensive and so they need to try medicine first?
Sure. I may have not been clear about that. Higher degrees of treatment resistance go along with less likelihood of doing well.
Yeah.
So it's not been examined in a treatment-naive population. Everyone who's been studied with TMS in the two big trials, the registration trial and the OpTMS trial, all had tried pharmacotherapy before they enrolled and had not done well. And the more things that they had tried and had not been of benefit, the less likely they were to get benefit from this round of treatment too.
And can you tell me what level 1 and level 2 are in the slide?
Sure. That's in the STAR-D trial. So in STAR-D, level 1 was people who got citalopram monotherapy for up to 12 weeks. Level 2 were people who either could augment that or switch to a different monotherapy. Level 3 were combinations. Level 4 were more exotic combinations.
So this took patients from the STAR-D and gave them TMS?
No. I'm sorry. It's a historical benchmark. It's not a head-to-head comparison. No one has yet done a trial where people are randomized to get either pharmacotherapy or TMS or different kinds of TMS. We have these two very large controlled trials, but there are lots more questions to answer yet.